share the screen in a minute. Okay. There's no disturbance to the voice now? Okay.
No, sir.
Okay, fine. Okay. Can you see the screen now?
Yes, sir. We can.
Okay, right. Right. When we talk about, going to talk about a kind of a group of disorders which are called gestational trophoblastic disease. Right? Now you know, in a normal situation, this is what happens normally. Okay, you have an egg being released, and you have the sperms entering, and they get fertilized. Okay, and start dividing into 2 cells, 4 cells, 8 cell, and all, and then divides into a blastocyst. Okay, now in a blastocyst, you have area that divides or grows into the fetus, and also you have a trophoectoderm, which finally forms the placenta, where you have the syncytial trophoblastic and the trophoblastic cells. Okay. Now, in this particular condition, and normally you will have the baby delivering from this area, and the placenta will deliver from the rest of, and you have a pregnancy. Now, in this condition, what happens is you don't get the fetal development normally. There is a rapid proliferation of the placental tissue. Right here, if you get a normal situation, it's like this. You got a normal placenta and a normal baby. Now, in these conditions called gestational trophoblastic disease, and it's a quite a wide spectrum of disorders. You get abnormal proliferation of the placenta, and so much so, in some situations, it might be just only the placental proliferated tissue that you can see within the uterine cavity. So I said it's a spectrum. Now, why does this happen? Now, normally you will have a baby and a placenta, and you will ultimately deliver a baby. But here, why does this abnormal proliferation of placental tissue occurs is explained through abnormal fertilization. Okay. Now there are situations where you can have basic problem here is, when you have fertilization of an ovum and a sperm, you have X and Y from the male and the female. Female contributes the sperm and the woman contributes the ovum, and this genetic material gets sort of mixed, and you have both male and female genetic material. Now here in this trophoblastic disease, what happens is, when you have a 46XX or XY, you find both sex chromosomes are from the male partner, from the paternal side. Whenever that happens, you have this abnormal placental proliferation. Now, it can happen in many ways. You can have a normal sperm fertilizing an egg, and then you can have duplication of the sperm genetic material, okay, and then start growing. So this particular zygote will have 46XX all from the male, and it leads to complete proliferation of the placenta tissue only without a fetus. So it's a monospermic situation. Otherwise, you can have both material, all chromosomes from the man. If two sperms get into an egg and the genetic material within the egg gets lost or ejected, then two sperms getting in means all will be from the man. Okay. Then you have this called dispermic situation, but both from the all the genetic material from the man, and this also will lead to an abnormal proliferation of the placenta. Okay. Now, most of the time, it is a single sperm getting duplication is what happens, but about 20% of the time, say 2/3 of, no, out of 3/4, 75% time, it's a single sperm, but breast about 25% of the time, it's two sperms fertilizing an egg, which ultimately leads to this situation called trophoblastic disease. Now, when this happens, and always you find there is no fetal development, then there can be another situation where two sperms gets into an egg where it will have 69 chromosomes, a triploidy. When you have this situation, again there are two male sperms getting in, and the genetic material is mostly from the man. Here also, this process of abnormal proliferation of the placenta does occur, but there is some fetal development. And we call these two conditions a complete mole and a partial mole. Now, this is the basic pathology or the abnormality that occurs in all this group of disorders called trophoblastic disease. Now, so this is what I said, genetically it can be 46XX because it's a single sperm, monosperm, about 75 to 80% of the time, and then small percentage, two sperms getting in, about 15%. Every time it's paternal origin. Now, when you say gestational trophoblastic disease, it's a group of disorders that occurs from ranges from a very benign condition to an extreme malignant condition, which even metastasizes. Okay. So the whole group of these disorders, so starting from a benign set going up to a malignant set, is called gestational trophoblastic disease. Okay. Then when you have, and usually most of the time it starts with a benign condition, and if once we treat this benign condition, the disease process continues and keeps on going, we call those set as gestational trophoblastic neoplasia. So all in all, gestational trophoblastic disease have two main areas: a benign primary component, which is non-neoplastic lesions, where you have abnormal proliferation, but they're benign. And they range from a small nodular proliferation in the placenta to a greater proliferation to a situation where there is complete filling of uterus with the placental tissue. And also a situation where sometimes you can get a fetus and a proliferated placenta, which is called a partial mole. And sometimes, although they are not highly malignant, they can be locally invasive as well. Then we call it what's an invasive mole. It's a something in between a benign and malignant thing, but it's only locally invasive. What is invasive? This abnormally proliferated placental tissue invades the myometrium. As I told you, once you get in this situation, these conditions will be treated. But if the disease process continues, that group is called this by the name gestational trophoblastic neoplasia. And there are a group of disorders which cause, it can be a locally invasive, as I say, the invasive molar pregnancy tissue, to extremely malignant situation called choriocarcinoma. And also you can have the certain two conditions called placental site trophoblastic tumor and epithelial trophoblastic tumor, which are sort of slightly different to extreme malignant situation where it becomes a locally malignant. Okay. Right. So this is what we talked about. Back again, just get this concept into your head properly. We have a benign component and we have extreme malignant component of this proliferated placenta. Okay. Right. Okay. So this I put it just in a simple this thing. You have benign component, we call it H mole, hydroform mole, complete aperture, including here also local placental proliferation like placental site nodules and things will come. But then if here, these ones where the disease process continues, even if you treat a complete hydroform mole, it can become, remaining things can become invasive, it can get malignant, and it can be locally malignant or disseminated malignancy both. Okay. Now, when you look at the benign ones, we'll talk about the benign ones first. The two most frequently seen, if there is only locally sort of proliferated placental tissue, sometimes you may not detect it because you can go with a normal baby also. But these two conditions, we call a partial hydatidiform mole. When you say partial hydatidiform mole, there is extensively proliferated placental tissue with a fetus. And when you say a complete hydatidiform mole, there is exaggeratedly proliferated placental tissue, but no fetal parts identified. But originally, they started with fertilization of an egg and sperm. It's generally more common in this part of the world compared to the other parts of the world. Okay. So you get incidence in about 1 in 1,500 in the West. Right? Here, average estimate is about 4 to 5 times better, higher than that. So this is the kind of incidence that we are talking about. Okay. Complete mole in about 1 in 1,000 and pregnancy, and partial 1 in 3,000 pregnancies. And the extremely malignant component that we talked about earlier, this occurs about 1 in 50,000. The other two conditions, which are locally malignant ones, the epithelioid ones and the placental site trophoblastic tumors, are rare. Now, there are certain groups of people who are at risk of developing this abnormal placental proliferation. One very important risk factor is age, extremes of age, older and young. Okay. So you see, when they are young, less than about 15 years, incidence is about 6 times higher than in a woman who is in the reproductive age group, maybe 20s and 30s. But if you are going beyond the age of 40, the risk gradually goes to about 5 to 6 times higher. And if you are 50 and beyond, the risk is extremely high. Okay. So this is mainly for hydroform mole, which mostly are complete. And there are other risk factors, like if you had previous gestational trophoblastic disease, then they are also more vulnerable or more likely to have a subsequent trophoblastic disease, which occurs in about, risk is about 1 in 75. If you had twice these abnormal pregnancies, your risk goes up to about 1 in 6. Now, you see this benign condition where you start with the pregnancy, very often presents to you like bleeding in pregnancy. Whether it's partial or complete mole, they generally, most of them present with bleeding in pregnancy.
Recording in progress.
Now, sometimes, on rare occasions, people might present with exaggerated vomiting, because if you remember that when you talked about hyperemesis glabellara, we said it's related to the pattern of HCG rise. Now, here you have excessive placental tissue, and then because of that, you have a very high levels of HCG, and people can come present to you with vomiting. Okay. And sometimes they present with passing of this proliferated placental tissue. If you look at them, they are just like a bunch of grapes. And these people who have this exaggerated placental proliferation with high levels of HCG, HCG and TSH, there's a common alpha subunit that's been shared. And they can present also with features of thyrotoxicosis or hyperthyroidism. Right. And although these are benign, I say these are benign lesions. The benign lesions usually do not metastasize. But this, the complete hydroform mole and the partial hydroform mole, they also can have or spread to mainly to the lungs, okay, and produce these like cannonball deposits in the lung, okay, due to embolization of these abnormal proliferated tissue. That is also more common in complete hydroform moles, which you get the full uterus filled with placental tissue. And when you have what we talked about, this partial hydroform mole, usually the symptoms are much less intense because they do produce less amount of HCG. Okay. and the symptoms may not be as strong as what we have. I said very often the patients presents with bleeding in early pregnancy, sometimes with vomiting, sometimes with features of hypothyroidism. But when they come, only thing you will know they are pregnant and they present to you. When you examine the abdomen, usually because of this rapid proliferation, you find the uterus becomes larger than the dates. Because of this high continuous HCG stimulation, you have these ovaries getting bigger with forming what are called theca lutein cysts, which sometimes are palpable abdominally. And they also are more prone to develop features of preeclampsia. Okay. So, when you do come, when you suspect, right? When you examine, you find these clinical features. But your confirmatory diagnosis obviously comes with investigations. And the most important investigation you would perform once we know, when you do a beta HCG or urine HCG, most important investigation you would do is doing a beta HCG level and an ultrasound scan. Okay. If you do a beta HCG level and if you find the level is high and you do an ultrasound scan, you will see the uterus without a fetus. Okay. You see the uterus without a fetus, fill the whole uterus like this. Here is what we call a complete hydromole, or sometimes with features like this, where there's a fetus also, but very often the fetus is dead. So it won't survive. And it's on the scan, you can also see this large cyst in the ovary. Right. So once you make a diagnosis, then you need to do certain other tests, right? Just to make sure you're not ending up with certain complications, because this proliferated placental tissue, I said sometimes they can sort of spread to other organs, metastasize or embolize, and produce some symptoms. And when they embolize to lungs and all, they are also prone to certain conditions like DIC. So you need to look at their coagulation, look at their liver, look at their renal functions. Obviously, you need some blood cross-match study because in case you have to take a theater, you have to be prepared. And you must do these investigations. And of course, with the scan, you confirm diagnosis. And I said the tissue can sometimes embolize, and of course, for you to see that, chest X-ray might be useful. But beyond that, doing extensive CTs, MRIs just for these cases are generally not recommended. But still, you must remember, in the extreme malignant situation, if you need to identify certain cerebral lesions and pulmonary and hepatic lesions, you may have to resort to CT and MRI, but not as a routine for these patients. Right. And what do you do? Now, when a patient comes to you, what happens? He comes with a positive pregnancy test, then you are a bit bleeding. You take HCG, you examine, she may or may not be having excessive vomiting. You have taken a history. And then you need to examine, investigate, and arrive at this diagnosis. Once you diagnose, what you need to do is, if she is bleeding, obviously you need her to be stabilized and give her blood if it's necessary. If it's hypertensive, she treats hypertension. Okay. If your TSH levels are high, okay, you look for it and be prepared for any kind of, if your thyroid hormone levels are high, be prepared for managing thyroid crisis. Okay. Then any pregnancy, if she's bleeding and rhesus negative, you also must try and administer anti-D rogam. Now, this once you obviously, when I say that if the bleeding is heavy, having your IV cannula seen, double O on both hands, making sure blood pressure is sort of maintained, all that comes. Now, for this condition where there is abnormal proliferation of placental tissue within the uterus, the treatment basically, you'll know, treatment is to remove this, what is inside the uterus, evacuate the uterus. Okay. Now, when you want to evacuate the uterus, what would you do? When a patient comes to you, imagine you are in the ward, she's bleeding, you take a history, you examine her, you know that she's possibly pregnant, you examine the fundus is much higher, you do an ultrasound scan, you find this abnormal trophoblastic disease, and then you need to treat it. Okay, obviously, when you treat, since she comes with bleeding, since the bleeding risk is high, have enough blood cross-match, get her hemoglobin up to a standard level, and then only you take her to theatre. Now, the treatment of choice or the method of choice for evacuation is using this suction curette. Okay, you will put one of these curettes inside and suck out this abnormal proliferated placental tissue. Right? Now, as you know, if you take a normal miscarriage, you have been taught, you can use certain other uterine stimulants like oxytocin, prostaglandins, misoprostol and all to evacuate the uterus. But here, generally using any kind of drugs to stimulate the uterus is not supported or not recommended, because once the uterus starts contracting, these abnormal proliferated placental tissues can embolize, especially to the lungs. Okay? So because of that, try to avoid uterine stimulants, but evacuate the uterus with the suction curette. But of course, when you have completely evacuated the uterus, you may be able to use some uterine stimulants. Now, I said this benign condition, this is a benign condition starting with, but it has a malignant potential. Because it's a malignant potential, you need to follow them up. Following them up, mainly, if you say, how are you going to follow them up? Follow them up with serial beta HCG measurements. Okay. Then, how long to follow up will depend on what happens to this trophoblastic disease over a period of time. Once you empty the uterus, if your beta HCG levels becomes normal within maybe 2 months and everything is completely cleared, then you might just follow up them for another about 4 to 5 months and release them. But if you have a situation where there is a complete hydrophore mole and you check the beta HCG levels and they are not sort of rapidly falling, but they are sort of slow to fall and all. If that is so, you need to follow them up at least for 6 months after the beta HCG levels have become normal. Okay. So once when you're following up, once the beta HCG levels are normal, then from there you follow up for about 6 months. Now, why are we following up? We are following up because we have dealt with gestational trophoblastic disease, but they can turn out to be gestational trophoblastic neoplasia and the malignant conditions. Because of that, we need to keep an eye. Okay, so sometimes you may need to follow up in your clinics, but for this follow up, most of the European countries have one center because this is a rare condition. You don't see it every time, and because of that, they have one center or you refer to those centers for regular follow up. Okay, and you will understand obviously during this time if you want to follow up with beta HCG levels, you should not get pregnant. Okay, so you must avoid a pregnancy roughly at least for a year after things have been sorted out, and you need to use contraception. Okay, now what is contraception wise? Using the IUCD is generally not recommended because with IUCD you can have irregular bleeding, and then it might interfere with your follow-up because sometimes every time she comes with bleed, you might think there is something going wrong, and then you might start interfering. Okay. Then the pill, oral contraceptive pill, can be used, but there's a second school of thought that people think that if you use the hormonal contraceptives, it can delay the clearance of HCG levels, but more recent data does not support it. But still, people are not very keen on giving contraception as the oral contraceptive pill. So the preferred method of contraception, until you sort out this for the next year, would be using some barrier method of contraception. And that is what usually recommended for contraception during the period of follow-up of gestational trophoblastic disease. Okay. When during the period of follow-up, you must know it's gradually goes down. Okay, you must know it goes down without suddenly having peaks and all different places. So once you chart and plot the beta HCG levels, you will just know it will plateau at some point. And once it becomes normal, follow up for about another period of 6 months in these cases. Okay. Now I said, now these ones can become malignant. The malignant potential or chance of this becoming malignant is more likely when you have a complete filling of uterus with this trophoblastic tissue than having a baby and a proliferated tissue, which is a partial mode. Okay. Okay. Right. And rarely, although I said usually this malignant component follows the benign ones, rarely you can straight on start a malignant situation as well, but that is not common. People can even present suddenly with a choriocarcinoma, but it's extremely rare to present like that. Right. So this is what we talked about earlier. You have benign to a complete mode. Okay. And to a malignant one, choriocarcinoma. Now, choriocarcinoma can occur after you have a complete hydrophore mole. It can occur after you had partial hydrophore mole. It can occur even after a miscarriage. It can occur even after a normal pregnancy. But more likely after a complete hydrophore mole. Right. Okay. Okay. So this I said, just a neoplasia most commonly follows a hydrophore mole. Okay. Right. But then if this benign ones turn out to be a extremely malignant situation, then you have this proliferated tissue where you end up not identifying the structure. It's extremely proliferated, while friable tissue, malignant, invades the muscle area. So this is a situation where it becomes a malignant following this initial episode of complete hydroform mole. Okay, so this again, I just show you. We started from here. It can start as a benign, but after completing treating immune evacuation, sometimes it turns out to be a malignant choriocarcinoma. When this becomes malignant, okay, I said this malignant potential can be locally malignant or disseminated malignancy. Locally malignant ones are the ones which we said invasive moles, and sometimes these other groups of things called placental site trophoblastic tumor. They are locally invasive. So if they are locally invasive, they can invade anterior to the bladder, posterior to the rectum, and surrounding to the parametrium. And the way that they spread, they will produce symptoms, hematuria, and all. And very important thing is the follow-up is always by using the HCG levels. If these are proliferating like that, then you find HCG levels will rise. And then you end up having this extremely malignant condition called choriocarcinoma. Okay. Now I said choriocarcinoma usually follows a complete hydroform mole or a partial hydroform mole, or sometimes even a normal pregnancy. And when they present with this malignant condition,
Recording in progress.
You can have sometimes spreading to the cerebrum, it is causing a focal signs. It can come with deposit in the liver, lung, right? All that are possibilities. So this is what I said, it can follow, trophoblastic neoplastic ones can follow complete hydroform mole, abortion, or normal delivery. And I told you this, you have a malignant locally spreading tumor compared to choriocarcinoma called placental site trophoblastic tumor, which is a slow growing tumor which gives late metastasis. And this particular tumor produces high levels of HPL, human placental lactogen. As a result, they comes with amenorrhea and galactorrhea and other symptoms. But here, very often, their HCG levels are low. So these ones, and you have this other group called epithelioid tumors. Again, I said these are extremely rare. This is again a locally malignant tumor. Okay. In both these conditions, epithelioid trophoblastic tumor and the placental site trophoblastic tumor, you find the HCG levels are low. Whatever said and done, now you are ending up with the malignant spectrum of disease, either gestational epithelioid trophoblastic disease or placental site trophoblastic tumor or malignant widely spreading choriocarcinoma. Okay. Now, when you have this situation, you need to now, okay. So these are the groups you can have: local benign ones, local malignant ones, malignant ones. Okay. When it becomes malignant one, obviously you need to stage the disease. Like in any other malignant disease, you can stage. The choriocarcinomas can be staged, and saying it's limited to the uterus, spreading beyond the uterus into adnexa and other tissues. Then if it spreads to lung and the liver and the other outside ones, okay. Or you can have extremely even to the brain and every eye in the body to malignant ones. When you have this gestational trophoblastic neoplastic condition, we earlier talked about the benign ones where you have to evacuate the uterus. Here you have the neoplastic condition. Okay. Here the mainstay of treatment for this is chemotherapy. Okay. Mainstay of treatment of gestational trophoblastic neoplasia is chemotherapy. Okay. But once you do an examination, for your follow-up, you must do the beta HCG levels. And of course, you must do a basic, whenever you diagnose gestational trophoblastic neoplasia, which is a malignant component, you must do a complete body survey to exclude presence of deposits in the lung, liver, spleen, and the brain, and other parts of the body. Okay, so that's why all these tests that are mentioned here have been done to see whether there is any spread of this involved to distant organs. Since this is a malignant one which is invading into the uterine muscle and all, you don't need to do curettages and take inside the uterus and do a histology. But when you have a patient with a PCF H-mole, during the follow-up, the HCG levels are rising, the scans and the other investigations showing that there is a rising HCG levels and spread of disease to other organs, then you may not necessarily looking at getting a histological diagnosis. Okay. If you can, you should, but sometimes you may not. Clinical picture will tell you that this is now spreading to a malignant situation. Now in this malignant, when they spreads to this choriocarcinoma and this malignant situation, the issue is you need to prognosticate them. Your next level of treatment will depend on this assessment, which is a scoring system, which will give you the prognostic indicators. Now, these are the indicators that are commonly used in these ones. Age, what was the previous pregnancy? That means, did the choriocarcinoma follow a H-mole or did it follow an abortion or ectopic pregnancy or what? The levels of HCG, okay, and the size of the tumor mass, metastasis, deposits, okay, and whether they have already had some chemotherapy and now again process is writing. Now all these are taken as prognostic factors and you give different scoring for this. And depending on that scoring, you categorize them as low and high risk. If the score is less than 6, you say it's low risk. If the score is higher than 6, you say it's high risk. So you have two groups of patients who are low risk and high risk. And then your treatment regime, I said this is the mainstay of treatment of choriocarcinoma is chemotherapy. And if it's only choriocarcinoma, without any other sort of distant organ involvement, and they are at low risk, then the drug of choice is methotrexate. Okay? You can treat with methotrexate those patients, and you may have to treat for a longer period of time. If you are in a high risk category, that means if you are in a multiple sort of risk factors, and then you have used, if you are high risk category, you have to use combination chemotherapy. That is, you use many drugs together, like in a sort of cancer situation. Okay, so don't worry about these regimes. Just to know, if you know that there is a single low risk people are treated with methotrexate, a single agent. High risk people are treated with multiple agents, including methotrexate, etoposide, actromycin, and all. Don't worry about these exact regimes because they can keep on changing as well. Okay. And then, of course, you need to follow them up. You follow them up mainly with beta HCGs and clinical examination. So initially, you follow them up quite frequently, maybe weekly, and then subsequently you follow them up about twice a month, then once a month, by measuring these beta HCG levels, by assessing their clinical history, by assessing their with ultrasound scans. Now, if they are responding to your chemotherapy, the HCG levels could now keep dropping, and once it stops, it has to remain at a lower level or below normal detection level. Now, rarely you can, this invasive trophoblastic tumor, which is a choriocarcinoma, of course, can give rise to complications. When it invades the uterus, it can erode into the serosa, it can start bleeding into the serosa and create a hemoperitoneum. Then if you, this choriocarcinoma spreads anterior, it might go into the bladder. Then the metastatic one can give complications. Right? So there are various problems that can occur as a primary. So there are certain things you have to think about. Now, I said choriocarcinoma is chemosensitive. So chemosensitive means no need of surgery most of the time. Okay. Right. Now, once they have got their complete treatment, I said, if you remember, we said you have to put them on contraception because if you get pregnant, you can't follow them up. I also told you, you must follow them up for about 6 months after the HCG levels have become normal. And generally, this period takes about 1 year or beyond. So usually, people after either the H-mole or choriocarcinoma specifically, you should wait for about 12 months before they get pregnant. Of course, provided they respond well. And good thing about this choriocarcinoma is they respond very well to chemotherapy. Either the low risk ones, I said single agent methotrexate, high risk ones, multiple drug therapy, chemotherapy, they often respond. This is one of the tumors, cancers, which almost sometimes have 100% survival. Okay. So when you, if you, I said you this chart, the risk categorization, if your score is less than 6, your survival is almost 100% with your chemotherapy, of course. But if you have a higher score, still over 94% of people do survive. So this is a cancer which have fairly good prognosis. Rarely you can have situations where there is metastatic tumor, gone to brain and liver and all, which may not respond to chemotherapy as well as in other patients. And then rarely, extremely rarely, you may have to locally resect them if it becomes necessary. Okay. That's why if you have this metastasis, of course, your chance of survival gradually drops. Okay. So that's why if you see these patients, you must treat them aggressively, start chemotherapy early without just waiting until your HCG keeps on increasing, and the prognosis will be poor. This is what I told you earlier. Sometimes for metastatic disease, you might need to locally excise the lesion because they may not respond to chemotherapy. And I told you at the beginning, other two rare conditions, the placental-side trophoblastic tumor and epidemiology trophoblastic tumor, they usually are less sensitive to the chemotherapy that we are using for cholecarcinoma. Okay? So they are localized ones. So they can be locally invasive, and they may not respond to chemotherapy very well. But good thing is they are extremely rare. Okay? Right. So that's what you should know about trophoblastic disease, and it's a spectrum of disorders, starting from benign to extreme malignant ones. Okay. It's the spectrum. It's a cancer malignancy that has good prognosis. It has good prognosis. Rarely metastatic disease, and this extremely rare type of ones, the placental-side trophoblastic tumors and epidioid tumors may have different outcomes, but overall, it's a cancer with good prognosis. If you are given a choice to have a cancer, this is one thing to have, because your 100% survival is more likely, and it's almost a cancer that is curable. Okay, that's why I said, even after this treatment, after about 1-2 years, you can still have a pregnancy and have a child as well. So that surgical treatment, hysterectomy and things are not the ideal management option for these patients. Okay. Right. If you have any questions, I can answer. You have another 3 minutes. So if you have no further questions, then we can wind up. Okay. Okay.